Good morning, everyone. Welcome to today's session. I'm excited to be here with you. Today, we'll be exploring a set of 20 multiple-choice questions with detailed explanations. The focus of our presentation is sickle cell anemia, a very important topic in hematology. We'll cover key concepts, diagnosis, management, and some interesting facts along the way. So let's get started and dive into this fascinating subject together. Let's look at this case of a 20-year-old man of African descent who is experiencing severe limb pain and a low-grade fever. The blood film reveals sickled cells, which suggests sickle cell disease. Now, the key question here is, what most likely triggered this sickling episode? Among the options, factors like viral infections, dehydration, iron deficiency, folic acid excess, and hypokalemia can all influence sickling, but some are more directly related. For instance, dehydration is a common trigger because it increases blood viscosity, making sickled cells more likely to block small blood vessels. Understanding these triggers is crucial in managing sickle cell crises. It helps us recognize how environmental or physiological stressors can precipitate symptoms. So, in this context, dehydration stands out as a major factor that can provoke sickling and worsen the clinical picture. This example ties into the broader theme of how various external and internal factors can influence hematological disorders like sickle cell disease, emphasizing the importance of preventing and managing these triggers to reduce crisis frequency. All right, so the correct answer here is B now. Let's talk a bit about vaso-occlusive crises. These episodes are quite common in conditions like sickle cell disease, and understanding what triggers them is really important. The main precipitating factors include dehydration, infection, and hypoxia. When the blood becomes dehydrated, it thickens, making it easier for the sickled cells to block blood flow. Similarly, infections can increase metabolic demand and cause inflammation, which also promotes vaso-occlusion. And hypoxia, or low oxygen levels, can cause the sickled cells to become more rigid and sticky, leading to blockages. Recognizing these triggers helps us better manage and prevent these painful crises, which ties back to our overall goal of improving patient outcomes through understanding disease mechanisms. All right, let's take a closer look at this case. We have a 25-year-old woman with known sickle cell disease, presenting with sudden, severe chest pain, a cough, and hypoxia. Those symptoms are quite concerning, and her chest X-ray shows new bilateral infiltrates. So what could be causing this? The key here is understanding that sickle cell disease often predisposes patients to certain complications, especially in the lungs. One of the most serious and common issues in this context is a pulmonary embolism, which can cause sudden chest pain and hypoxia. But we should also consider acute chest syndrome, which is a unique complication of sickle cell disease itself. It presents with chest pain, respiratory symptoms, and new infiltrates on imaging, exactly what we see here. Other possibilities include pneumonia, which causes similar symptoms, but the rapid onset and the patient's background make this less likely. Heart failure could cause pulmonary edema and infiltrates, but it's less typical in a young, otherwise healthy individual. And pleural effusion, while it can cause chest pain and dyspnea, usually has different radiographic features. So, in this scenario, the most likely diagnosis is either acute chest syndrome or pulmonary embolism. But given the bilateral infiltrates and the sickle cell background, acute chest syndrome is at the top of the list. Recognizing these key features helps us differentiate between these potential causes and guides appropriate management. This example underscores how important it is to consider the overall clinical context, especially underlying conditions like sickle cell disease, when evaluating chest symptoms. All right, so the correct answer here is B now. Let's break down what acute chest syndrome actually is. It's characterized by the presence of a new pulmonary infiltrate, which means some new abnormality or opacity on the chest imaging, combined with respiratory symptoms. And importantly, this occurs in a patient with sickle cell disease. So, when you see a sickle patient presenting with chest pain, cough, or difficulty breathing, along with new infiltrates on their X-ray, you should be thinking about acute chest syndrome. This is a serious complication, and recognizing it quickly is key for prompt treatment. It really ties into the overall theme of managing sickle cell crises and preventing severe outcomes. Let's examine the possible causes of anemia in this young boy with sickle cell disease. First, we have parvovirus B19 infection, which is known to cause aplastic crises by temporarily shutting down red blood cell production. This is especially relevant here because his reticulocyte count is low, indicating decreased red cell production. Next, iron deficiency anemia can also cause pallor and lethargy, but it typically presents with a low reticulocyte count as well, though it's less common in sickle cell patients unless there's poor intake or bleeding. Sequestration crisis is another important consideration, where sickled cells get trapped in the spleen, leading to rapid spleen enlargement and anemia, but usually it presents with splenomegaly and a different blood picture. Malaria is also a cause of hemolytic anemia, especially in endemic areas, and can cause fever and anemia, but the recent fever and rash point more toward a viral infection. Lastly, folic acid deficiency impairs red blood cell production, causing anemia, but again, the presence of recent fever and rash suggests an infectious process rather than a nutritional deficiency. Connecting all these points, given the recent fever, rash, and low reticulocyte count, the most likely cause here is parvovirus B19 infection triggering an aplastic crisis. This situation exemplifies how infections can transiently worsen anemia in sickle cell disease. Answer: A. So, the key point here is that parvovirus B19 plays a specific role in certain hematologic conditions. The virus actually suppresses erythropoiesis, which is the process of producing red blood cells in the bone marrow. Because of this suppression, it can lead to an aplastic crisis, especially in individuals who already have underlying hemolytic disorders. In such cases, you'll see a significant drop in reticulocytes, which are the young red blood cells in circulation. This reduction explains why patients may develop severe anemia during an infection with parvovirus B19. Understanding this mechanism is crucial because it highlights how viral infections can directly impact blood cell production and lead to clinical crises. Now, let's consider a scenario involving a 6-year-old child with sickle cell disease who suddenly develops abdominal distension and shock. Notably, the spleen is enlarged in this case. This presentation points to a specific complication. When we see an enlarged spleen in a sickle cell patient, especially with such acute symptoms, it suggests a sequestration crisis. Sequestration crisis occurs when a large volume of sickled cells become trapped in the spleen, causing it to enlarge rapidly and leading to hypovolemic shock. This is a potentially life-threatening situation that requires prompt recognition and management. Understanding this helps us connect to the broader theme of sickle cell crises, which include various types like aplastic, vaso-occlusive, hemolytic, and acute chest syndrome. But in this particular case, the key is the sudden spleen enlargement coupled with shock, pointing us toward sequestration crisis. Always remember, early diagnosis and intervention are crucial to prevent severe outcomes in such scenarios. All right, let's talk about splenic sequestration crisis. The answer here is A. So, what exactly happens in this situation? Essentially, there is an acute pooling of blood within the spleen. This means that a large volume of blood gets trapped there suddenly. As a result, the blood volume circulating in the rest of the body drops significantly, leading to hypovolemic shock. This is a serious emergency because the reduced blood flow can compromise multiple organ functions. Understanding this process is crucial because it highlights how spleen-related issues can rapidly become life-threatening if not managed promptly. All right, let's walk through the next steps in managing this case of priapism. First, it's important to reassure the patient and observe closely. This helps us monitor the situation without jumping to invasive procedures prematurely. Next, giving oral fluids can help promote hydration, which may aid in resolving the priapism. If the situation persists, we consider aspirating and irrigating the corpora cavernosa. This is a more direct approach to relieve the trapped blood and reduce the pain. Additionally, administering sildenafil might seem counterintuitive, but in certain cases, it can help by improving blood flow dynamics. Finally, for patients with sickle cell disease, addressing the underlying issue is crucial. Starting iron chelation therapy can help manage iron overload from repeated transfusions, which is a common concern in these patients. Overall, these steps form a comprehensive approach, starting from observation and supportive care, progressing to targeted interventions, and addressing the root cause, ensuring we provide the best care for the patient. Answer: see now, let's discuss why this is the correct choice. Priapism is considered a vaso-occlusive emergency, which means that the blood flow in the penis becomes trapped and blocked. This situation requires urgent intervention to prevent long-term damage. The key treatment here is aspiration, where we drain the blood from the corpora cavernosa to relieve the pressure. If not treated promptly, priapism can lead to fibrosis and ultimately cause impotence. So, recognizing the emergency and acting quickly with aspiration is crucial to preserve future erectile function. This highlights the importance of understanding vascular emergencies and their timely management within our overall approach to patient care. Today, we're looking at the different types of gallstones that can form in the gallbladder. The options include cholesterol stones, pigment stones, which are primarily made of bilirubin mixed stones that contain a combination of components, calcium oxalate and uric acid stones. In this particular case, we have a young man, just 23 years old, with sickle cell disease. He presents with fever and right upper quadrant pain, and ultrasound shows gallstones. Knowing that sickle cell disease often leads to increased hemolysis, this causes an excess of bilirubin. So, the gallstones in this patient are most likely pigment stones, which are primarily composed of bilirubin. This highlights an important point. Certain conditions, like hemolytic diseases, predispose patients to pigment stones because of the increased breakdown of red blood cells. Understanding the composition of gallstones helps us grasp the underlying causes and guides appropriate management. It also ties into the broader theme of how systemic diseases can influence local pathologies like gallstone formation. Answer is B now. Let's break down why that's the correct choice. Chronic hemolysis, which is ongoing destruction of red blood cells, leads to an increase in bilirubin levels. As bilirubin builds up, it can cause pigment gallstones to form. These stones are primarily composed of bilirubin, and their development is directly linked to the excess bilirubin from the hemolysis. So, understanding this pathway helps us connect the dots between hemolytic conditions and gallstone formation. This concept is important because it highlights how chronic hemolytic states can lead to specific complications like pigment gallstones. Let's analyze what we expect in this case. The woman has sickle cell disease, which often causes hemolysis, leading to anemia and jaundice. Her hemoglobin is quite low at 6.5 grams per deciliter, and she shows signs like reticulocytosis, which indicates the bone marrow is responding by producing more red blood cells. Scleral icterus also suggests increased bilirubin levels. Now, considering these features, what lab abnormality would we expect? Increased haptoglobin is unlikely because it binds free hemoglobin released during hemolysis and typically decreases when hemolysis is active. Decreased LDH is also unlikely because LDH tends to be elevated in hemolysis. Increased unconjugated bilirubin makes sense because the breakdown of hemoglobin releases bilirubin that hasn't been processed by the liver yet. A positive Coombs test indicates immune-mediated hemolysis, but sickle cell hemolysis is usually not immune-mediated. Lastly, low indirect bilirubin wouldn't fit because in hemolytic states, indirect bilirubin is usually elevated. So the most consistent lab abnormality here would be an increase in unconjugated bilirubin, reflecting the increased breakdown of hemoglobin from hemolysis. This ties into the overall theme of hemolytic anemia in sickle cell disease. Answer is C, and let's explore why that's correct. When we see intravascular or extravascular hemolysis happening, certain laboratory findings are characteristic. For example, there's an increase in indirect bilirubin, which occurs because the breakdown of hemoglobin releases bilirubin that hasn't yet been processed by the liver. We also see an increase in LDH, or lactate dehydrogenase, which is released from lysed red blood cells. And finally, haptoglobin levels tend to decrease because it binds free hemoglobin released during hemolysis, and once saturated, its levels drop. So, recognizing this pattern helps us identify hemolytic processes. These points are essential because they connect the biochemical changes directly to the underlying pathology, fitting into our overall understanding of hemolytic anemias. Let's take a closer look at the medications listed here. First, we have folic acid, which is actually quite important for pregnant women, especially those with sickle cell disease, because it helps support fetal development and red blood cell production. Next is hydroxyurea, which is a key medication for managing sickle cell disease as it reduces the frequency of sickling episodes. Then there's penicillin, commonly used to prevent infections in these patients. Iron supplements are also important to address anemia, which is common in sickle cell disease. Lastly, paracetamol is used for pain relief and is generally safe during pregnancy. Now, considering all of these, the critical question is, which medication should be avoided in a pregnant woman with sickle cell disease? The answer is hydroxyurea. It's known to be teratogenic, meaning it could harm the developing fetus. Therefore, in this context, hydroxyurea should be avoided to ensure the safety of both the mother and the baby. This highlights the importance of carefully choosing medications during pregnancy, especially in conditions like sickle cell disease. So the correct answer here is B now. To clarify, hydroxyurea is actually teratogenic, which means it can cause birth defects. Because of this, it's very important to avoid using hydroxyurea during pregnancy. This is a key point to remember, especially when managing patients who might become pregnant while on this medication. Ensuring safety for both the mother and the developing fetus is always a top priority, and avoiding teratogenic drugs during pregnancy is a crucial part of that. This ties into the overall theme of understanding medication safety in different patient populations. Now, let's consider the options for long-term prophylaxis in a 10-year-old child with sickle cell disease. First, daily folic acid only. While folic acid is important for red blood cell production, on its own, it doesn't prevent the complications associated with sickle cell disease. Next, daily penicillin prophylaxis. This is a well-established strategy, especially in young children, to prevent infections like pneumococcus, which can be life-threatening in sickle cell patients. Then, we have monthly blood transfusions. These are typically reserved for preventing stroke or managing severe complications, but they come with risks like iron overload. Hydroxyurea is another option. It increases fetal hemoglobin, which reduces sickling and associated symptoms. It's proven effective in decreasing pain crises and other complications. Lastly, aspirin. While it can be used for stroke prevention in some cases, it's not the primary prophylactic measure for infection or anemia. So, considering the overall goal of preventing infections and the evidence-based guidelines, the most appropriate choice here is daily penicillin prophylaxis. It's a cornerstone in managing children with sickle cell disease to prevent serious infections and improve long-term outcomes. Alright, so the correct answer here is B now. To explain why, children with sickle cell disease, or SCD, have a higher risk of serious infections, especially from certain bacteria. That's why they need to be on penicillin prophylaxis, which is a preventative antibiotic to help protect them from these infections. Additionally, pneumococcal vaccination is crucial because the pneumococcus bacteria is a common cause of severe infections in these children. Ensuring they receive these preventive measures is essential in managing their health and reducing complications. This ties back to our overall theme of early intervention and preventive care in managing sickle cell disease effectively. Let's take a closer look at this case. We have a 19-year-old man diagnosed with sickle cell anemia, and he's presenting with fatigue and jaundice, which are common symptoms related to hemolysis. Now, his hemoglobin electrophoresis shows 95% HbS, only 3% HbF, and no HbA detected. This pattern is quite characteristic. The high percentage of HbS indicates that most of his hemoglobin is the sickled form. The absence of HbA suggests that he doesn't have normal adult hemoglobin, which is typical in sickle cell anemia. The small amount of HbF can sometimes provide some protective effect, but isn't enough to prevent symptoms. So, putting it all together, this electrophoresis pattern confirms a diagnosis of sickle cell anemia, or homozygous HBSS disease. This case highlights how electrophoresis results directly inform us about the hemoglobin types present and help us diagnose specific hemoglobinopathies. Remember, understanding these patterns is crucial for accurate diagnosis and management of these conditions. Let's look at this example. The correct answer here is B when we see the HBSS pattern. That indicates sickle cell anemia, which is the homozygous form. Now, in the trait or carrier state, you'll notice that HbA is still present. This is important because it reflects the heterozygous status, meaning the individual carries one sickle cell gene and one normal hemoglobin gene. Recognizing these patterns helps us distinguish between the disease and the trait, which is crucial in genetic counseling and diagnosis. So, to sum up, the HBSS pattern points to sickle cell anemia, while the presence of HbA in the trait shows that the person is a carrier, not affected by the disease itself. Let's discuss the factors that can trigger hematuria in a person with sickle cell trait. First, high altitude can be a problem because the lower oxygen levels cause more sickling of the red blood cells, which can damage the small blood vessels in the kidneys. Next, a high-fat diet can increase the workload on the kidneys and potentially lead to stress on the renal vasculature. Third, high carbohydrate intake, especially in the context of metabolic changes, might influence blood viscosity and sickling tendencies. Fourth, alcohol intake can cause dehydration and vasodilation, both of which may promote sickling and hematuria. Lastly, heat exposure can lead to dehydration, thickening the blood, and increasing the risk of sickling episodes in the renal microvasculature. So, in summary, these environmental and dietary factors, especially high altitude and heat exposure, are key triggers that can provoke sickling in the renal vessels and lead to hematuria in someone with sickle cell trait. Recognizing these risks helps us understand how external conditions can impact the clinical presentation, even in asymptomatic individuals. Let's take a look at this question. The answer is A, and the key explanation here is that sickle cell trait is generally considered benign, meaning it doesn't usually cause problems. However, under certain conditions, such as hypoxia, which is when the body or tissues are deprived of oxygen, it can lead to some issues. One notable example is hematuria, which is blood in the urine. This can happen especially at high altitudes, where the oxygen levels are lower. So, even though most people with sickle cell trait are healthy and don't experience symptoms, it's important to be aware that in specific situations like hypoxia, they might develop complications like hematuria. This ties into our overall theme of understanding the different hemoglobinopathies and their clinical implications. Recognizing these triggers helps us manage patients better and anticipate potential issues, especially in situations where oxygen levels might drop. Now, in this case, we have a 24-year-old woman with sickle cell disease who has just been identified as having a stroke. So, what's the next step in management? First, it's important to recognize that in sickle cell disease, stroke risk is quite high, and prompt intervention is crucial. Looking at the options, IV thrombolysis might be considered in certain stroke cases, but in sickle cell disease, the primary approach often involves exchange transfusion, which helps reduce the percentage of sickled cells and restores normal blood flow. Exchange transfusion has been shown to be effective in managing acute stroke in these patients. Aspirin can be used for secondary prevention in some strokes, but it's not typically the immediate response in sickle cell-related stroke. Hydroxyurea, meanwhile, is mainly for preventing future sickling episodes by increasing fetal hemoglobin, but it isn't an acute intervention. And prednisolone, a steroid, doesn't play a primary role in stroke management in sickle cell disease. So, considering all this, the most appropriate next step here is exchange transfusion. It's a targeted, effective approach to rapidly reduce sickled cells and improve cerebral blood flow in this critical situation. Alright, so the correct answer here is B now. Let's talk about why that is. Exchange transfusion is a really effective intervention because it rapidly lowers the concentration of hemoglobin S, or HbS, in the blood. By doing this, it helps to decrease the sickling of red blood cells, which is at the core of sickle cell complications. Additionally, this procedure significantly improves oxygenation. When we remove the sickled cells and replace them with healthy donor blood, oxygen delivery to tissues improves quickly. This approach is especially crucial in severe cases where quick action can make a big difference in patient outcomes. So, overall, exchange transfusion is a key strategy in managing sickle cell crises because of its rapid effect on reducing HbS levels and enhancing oxygen supply to the body. Let's look at a clinical scenario involving a 14-year-old boy with sickle cell anemia who presents with worsening bone pain and swelling in his leg. The X-ray reveals periosteal elevation, which suggests an underlying bone infection or inflammation. Now, considering his sickle cell disease, certain infections are more common due to altered immune responses and frequent vaso-occlusive crises. When we think about the likely causative organisms, Salmonella stands out as the most common pathogen responsible for osteomyelitis in sickle cell patients. Salmonella has a propensity to invade the bone in these individuals, leading to the periosteal elevation we see here. Other bacteria like Staphylococcus aureus are common causes of osteomyelitis in the general population, but in sickle cell disease, Salmonella is more prevalent. Streptococcus pneumoniae typically causes pneumonia or meningitis, especially in young children, rather than osteomyelitis. E. coli and Pseudomonas aeruginosa are more associated with infections in specific settings, like urinary tract infections or nosocomial infections, respectively. So, in this context, the most likely organism responsible for this patient's bone infection is Salmonella. Recognizing this helps guide appropriate treatment and highlights the importance of understanding how underlying conditions like sickle cell anemia influence infection patterns. So the answer here is A, which is Salmonella. Now, why is Salmonella the most common cause of osteomyelitis in sickle cell disease? Well, it's because of the unique way sickle cell affects the bones. In SCD, you often see bone infarction, which is essentially tissue death due to lack of blood supply. This creates an environment that's particularly susceptible to certain bacteria, and Salmonella has a special affinity for these damaged bones. Unlike other bacteria, Salmonella can invade and thrive in these infarcted areas, leading to osteomyelitis. So, understanding this link helps us better target our diagnosis and management strategies in patients with sickle cell disease. Let's look at some potential underlying mechanisms for leg ulcers in this context. First, venous insufficiency can lead to poor blood flow back from the legs, causing venous hypertension and tissue breakdown. Next, microvascular occlusion, which is common in sickle cell disease, can block small blood vessels, impairing healing and causing tissue ischemia. Infection is another factor. It can complicate ulcers and hinder recovery. Pressure injury, or skin breakdown due to sustained pressure, is also a possibility, especially if mobility is limited. Lastly, arterial embolism involves blockage of larger arteries, reducing blood supply and leading to ischemic ulcers. In this case, considering the patient's sickle cell disease, the most relevant mechanism is likely microvascular occlusion, where sickled cells obstruct small vessels, impairing blood flow and preventing the ulcer from healing properly. This highlights how sickle cell disease affects microcirculation and can lead to chronic wounds. Understanding these mechanisms helps us target the right treatment strategies to promote healing and prevent complications. Alright, so the correct answer here is B now. Let's break down why that is. Chronic microvascular occlusion, which means small blood vessels get blocked over time, leads to reduced blood flow to the tissues. This decreased perfusion causes tissue ischemia, or in simpler terms, a lack of oxygen and nutrients. As a result, this can lead to the development of ischemic leg ulcers. These ulcers are typically painful and slow to heal because the underlying blood supply is compromised. So, understanding this pathophysiology helps us recognize the importance of microvascular health in preventing such ulcers, especially in patients with conditions like diabetes or peripheral vascular disease. This ties into our broader discussion on vascular issues and their clinical manifestations. Now, let's consider a scenario involving a 5-year-old child with sickle cell disease, or SCD. Because of their condition, they have a higher risk of developing severe sepsis, primarily due to the loss of splenic function. The spleen plays a critical role in filtering bacteria from the blood, especially encapsulated organisms. So, when we think about which organism is most likely to cause severe sepsis in this context, we need to focus on bacteria that are particularly problematic for individuals without a fully functioning spleen. Among the options listed, Escherichia coli, Streptococcus pneumoniae, Staphylococcus aureus, Klebsiella, and Listeria. Streptococcus pneumoniae stands out as the most common and dangerous pathogen responsible for severe infections in patients with asplenia or splenic dysfunction. This highlights the importance of vaccinations and prophylactic measures in children with sickle cell disease to prevent infections by such encapsulated bacteria. Recognizing these risks helps us in early intervention and tailored care for these vulnerable patients. All right, let's look at this slide. The answer here is B, which is important to note. When we talk about functional asplenia, we're referring to a condition where the spleen isn't working properly, even if it appears normal on imaging. This condition significantly increases the risk of infections, especially from encapsulated organisms. The most notable one is Streptococcus pneumoniae, or S. pneumoniae. Because the spleen plays a critical role in filtering bacteria and mounting an immune response, its dysfunction means these bacteria can cause severe infections more easily. So, understanding this connection helps us appreciate why patients with functional asplenia need careful monitoring and sometimes prophylactic measures. This concept ties into the broader theme of how immune deficiencies predispose individuals to specific infections, highlighting the importance of recognizing these risks early. Let's look at the options for this patient's likely chronic complication. Pulmonary hypertension is a serious issue in sickle cell disease, but it typically presents with symptoms like shortness of breath and chest pain rather than fatigue and pallor. Iron overload can occur due to frequent transfusions, leading to liver or heart problems, but it doesn't usually cause the anemia seen here. Chronic kidney disease is a possibility, as sickle cell can damage the kidneys, but it often presents with additional signs like changes in urine. A vascular necrosis of the femur is common in sickle cell disease, but it mainly causes joint pain and mobility issues rather than anemia or pallor. Folate deficiency, on the other hand, is a well-known cause of anemia, especially in patients with chronic hemolytic conditions like sickle cell disease. It can lead to ineffective red blood cell production, which explains the chronic fatigue and pallor, along with the blood film showing target cells and sickled cells. These findings point toward folate deficiency as the likely chronic complication in this case. All right, let's look at this question. The correct answer is D now. What this is really highlighting is the concept of a vascular necrosis of the femoral head. This condition occurs when the blood supply to the femoral head is compromised, leading to tissue death. The key point here is that repeated bone infarctions, or areas where the bone tissue dies due to lack of blood flow, are quite common in this scenario. These infarctions can accumulate over time, weakening the bone structure and eventually causing collapse. Understanding this process is important because it helps us recognize the risk factors and mechanisms behind femoral head necrosis. So, In the context of our overall discussion on bone pathologies, this example underscores how vascular issues can directly lead to significant structural damage in bones like the femoral head. All right, let's consider the options for long-term therapy in a 30-year-old man with sickle cell anemia who's experiencing recurrent crises. The goal here is to find a treatment that actually reduces how often these crises happen. Starting with hydroxyurea, this is actually the most well-supported option for decreasing the frequency of sickle cell crises. It works by increasing fetal hemoglobin production, which helps prevent the sickling of red blood cells. Now, prednisolone, which is a corticosteroid, can be useful in acute settings, but it's not typically used for long-term management to prevent crises. Methotrexate is more associated with autoimmune conditions like rheumatoid arthritis, so it's not relevant here. Erythropoietin stimulates red blood cell production, but it doesn't specifically reduce crisis frequency in sickle cell disease. And then there's interferon, which is used for certain viral infections and some cancers, but it's not relevant for sickle cell management either. So, in the context of reducing the recurrence of crises, hydroxyurea stands out as the most effective long-term therapy. This highlights the importance of targeted treatments that modify the disease process itself, rather than just managing symptoms. Answer A. So, the correct answer here is option A. Now, let me explain why. Hydroxyurea is a medication that works by increasing the production of fetal hemoglobin, or HbF. And this increase in HbF is really important because it helps reduce the sickling of red blood cells. When sickling is reduced, patients tend to experience fewer sickling crises, which are episodes of severe pain and complications. So overall, hydroxyurea not only helps improve blood flow, but also decreases the frequency and severity of these crises. That's why it's a key part of managing sickle cell disease effectively. Understanding this mechanism helps us appreciate how targeted therapies can make a real difference in patient outcomes. Let's discuss the best management options for this 25-year-old man with sickle cell anemia who has developed high ferritin levels after multiple transfusions. First, stopping transfusions altogether can be considered, especially if iron overload is a concern, but it's not always feasible if transfusions are still necessary for managing his anemia. Next, chelation therapy with deferocerox is a key point here. This medication helps to remove excess iron from the body, which is crucial when dealing with iron overload caused by frequent transfusions. Giving vitamin C can enhance iron chelation because it helps mobilize iron stores, making chelation more effective. Erythropoietin can stimulate red blood cell production, but in this context, it's less directly relevant since the main issue is iron overload from transfusions. Finally, folic acid is important for red blood cell production, but again, in this scenario, the primary concern is managing iron overload through chelation therapy. So, considering all these options, the most appropriate management here is chelation therapy with deferocerox to address the iron overload resulting from repeated transfusions. Let's look at this question about managing iron overload. The correct answer is B. When we encounter iron overload, the key is to reduce the excess iron in the body. This is typically done through iron chelation therapy. Two common agents we use are deferocerox and deferoxamine. These medications bind to the excess iron, allowing it to be excreted more easily. It's important to recognize iron overload early because if left untreated, it can cause damage to organs like the liver, heart, and endocrine glands. So, effective chelation therapy is crucial in managing this condition and preventing serious complications. Let's consider this case of a 27-year-old woman with sickle cell disease who is experiencing dyspnea and chest pain. Her echocardiogram indicates pulmonary hypertension, which raises an important question. What is the most likely cause in her situation? Looking at the options, chronic hemolysis stands out as a key contributor here. In sickle cell disease, ongoing destruction of red blood cells releases hemoglobin into the bloodstream, a process known as hemolysis. This free hemoglobin can scavenge nitric oxide, a critical molecule that helps keep blood vessels dilated and prevents increased vascular resistance. When nitric oxide availability decreases, it leads to vasoconstriction and promotes the development of pulmonary hypertension. This is a well-recognized complication in sickle cell disease due to chronic hemolysis. Other options like heart failure, thalassemia, iron deficiency, or infection might also influence overall health. But in this specific context, pulmonary hypertension associated with sickle cell disease, chronic hemolysis is the primary driver. This case underscores how the pathophysiology of sickle cell disease, especially chronic hemolysis, can directly impact the pulmonary vasculature, leading to serious complications like pulmonary hypertension. So the answer here is A, and to understand why, let's walk through the explanation. Chronic hemolysis, which is the ongoing destruction of red blood cells, leads to a depletion of nitric oxide. Now, nitric oxide is a crucial molecule that helps keep our blood vessels dilated and healthy. When there's less nitric oxide, blood vessels tend to constrict more than they should. This vasoconstriction increases the resistance within the pulmonary circulation, which can ultimately result in pulmonary hypertension. So, in essence, chronic hemolysis sets off a chain reaction. It depletes nitric oxide, and that depletion contributes significantly to the development of pulmonary hypertension. This connection is important because it highlights how a blood disorder can have widespread effects on the cardiovascular system. All right, imagine this scenario. A 22-year-old man with sickle cell disease comes in with a hemoglobin level of 7 grams per deciliter, a high reticulocyte count, and worsening jaundice. So, what does this tell us? Well, the low hemoglobin indicates anemia, but the high reticulocyte count shows his bone marrow is actively trying to produce more red blood cells. The worsening jaundice suggests increased breakdown of these cells. Now, among the different types of sickle cell crises, this presentation most closely points to a hemolytic crisis. That's when there's excessive destruction of red blood cells, leading to anemia and jaundice. The body responds with increased reticulocyte production to compensate. It's important to understand that hemolytic crises are common in sickle cell disease because sickled cells tend to break apart easily. This is different from other crises, like aplastic crises, where the marrow's production drops, or sequestration crises, where blood pools abnormally in the spleen. So in this case, the key features, low hemoglobin, high reticulocytes, and jaundice, are classic signs pointing toward a hemolytic crisis. Recognizing these signs helps us provide the right management and understand the disease process better. Answer A. So, when we talk about a hemolytic crisis, we're referring to a sudden and rapid increase in the destruction of red blood cells. This is what we call an acute acceleration of hemolysis. And an important feature to look for during this crisis is reticulocytosis, which is an increase in reticulocytes, or immature red blood cells, indicating that the bone marrow is responding actively to the increased destruction. This concept ties into our broader discussion of hemolytic anemias, where understanding the dynamics of red blood cell destruction and production is crucial for diagnosis and management. So, in summary, a hemolytic crisis is characterized by a sudden spike in hemolysis, accompanied by reticulocytosis, signaling the bone marrow's response to the increased demand for new red blood cells. Let's wrap up with a quick summary of sickle cell anemia. This condition is a good example of how genetic factors can significantly impact health. We've seen how the abnormal hemoglobin causes the red blood cells to become sickle-shaped, which leads to blockages in blood flow and causes pain and organ damage. It's important to remember that this disease primarily affects individuals of African, Mediterranean, Middle Eastern, and Indian ancestry. Understanding the pathology helps us appreciate the importance of early diagnosis and management strategies. Overall, Sickle cell anemia highlights the critical need for ongoing research and tailored treatments to improve quality of life for those affected. This slide highlights an autosomal recessive hemoglobinopathy, which means the condition is inherited when a person receives 2 copies of the mutated gene, one from each parent. The key mutation here is a point mutation in the beta-globin gene, where a glutamic acid, or GLU, is replaced by a valine, or VAL. This small change has a big impact because it leads to the production of hemoglobin S, or HbS. Now, under low oxygen conditions, this abnormal hemoglobin causes red blood cells to sickle or deform. These sickled cells can block blood flow and cause various complications. Understanding this mutation and how it affects red blood cell shape is crucial in grasping the pathology of sickle cell disease. So let's talk about how sickle cell hemoglobin, or HbS, behaves under certain conditions. When oxygen levels drop, HbS tends to polymerize or stick together, which causes the red blood cells to change shape. Instead of their normal round, flexible form, they become distorted into a sickle shape. This sickling of the cells is a key feature of sickle cell disease. This shape change has several consequences. First, it causes the red blood cells to become less flexible and more prone to sticking together, which can block small blood vessels, a process known as vaso-occlusion. This blockage leads to ischemia, or insufficient blood supply, which often results in painful episodes called crises. Second, because sickled cells are more fragile and tend to break apart easily, we see increased hemolysis, or destruction of red blood cells. This ongoing destruction leads to anemia, a shortage of healthy red blood cells, and jaundice, which is that yellowish discoloration of the skin and eyes caused by the breakdown products of hemoglobin. Third, the spleen, which normally filters out abnormal or old red blood cells, can become infarcted or damaged due to repeated blockages. Over time, this results in functional asplenia, a state where the spleen no longer functions properly and significantly increases the risk of infections. Overall, these mechanisms, polymerization, vaso-occlusion, hemolysis, and splenic damage, are central to understanding the complex pathophysiology of sickle cell disease and why patients experience such a range of complications. Let's take a closer look at the clinical features associated with this condition. In the chronic phase, patients often experience fatigue, which is quite common due to anemia. Pallor and jaundice are also typical, reflecting the breakdown of red blood cells. Gallstones can develop as a result of increased bilirubin from hemolysis. When it comes to crisis types, there are several important categories. The vaso-occlusive crisis is characterized by painful episodes caused by blockages in blood flow. Aplastic crises happen when reticulocyte production drops significantly, and this can be triggered by infections like parvovirus B19. Sequestration crises involve pooling of blood in the spleen, leading to sudden hypovolemia. Hemolytic crises involve accelerated destruction of red blood cells, resulting in increased reticulocyte production as the body tries to compensate. Now, moving on to potential complications, these can be quite severe. Stroke is a major concern due to the risk of blocked blood flow in the brain. Osteomyelitis, especially from salmonella infections, is more common in these patients. Other complications include avascular necrosis, which affects the bones, pulmonary hypertension, leg ulcers, priapism, and even renal papillary necrosis. Understanding these clinical features is crucial because they highlight the broad impact this disease can have on multiple systems. Recognizing these patterns helps us manage and anticipate complications more effectively as part of comprehensive patient care. Now, looking at the blood film, we can see sickled cells and target cells, which are characteristic features in this condition. These abnormal cells are a key clue pointing towards sickle cell disease. Moving on to the hemoglobin electrophoresis results, we see that HbS is predominant, and importantly, there's no HbA present in cases of HbSS. This confirms the diagnosis of sickle cell anemia. In addition, the lab findings often include reticulocytosis, indicating increased red blood cell production in response to hemolysis. We also see elevated bilirubin and LDH levels, which are markers of ongoing red cell destruction. Conversely, haptoglobin levels tend to be decreased because it gets used up when it binds free hemoglobin released during hemolysis. Putting all these investigations together helps us not only confirm the diagnosis, but also understand the extent of hemolysis and bone marrow response. This comprehensive picture is crucial for guiding effective management of the patient. Now, let's take a closer look at the management strategies for sickle cell disease across different stages and goals. Starting with prevention, the key here is to avoid factors that can trigger complications. This means staying well hydrated, keeping warm to prevent cold exposure, and preventing infections, which can significantly worsen the condition. Moving on to managing infections, vaccination is crucial, particularly against pneumococcal, meningococcal, and Hib bacteria. Additionally, penicillin prophylaxis is often used to reduce the risk of bacterial infections in these patients. In the event of a crisis, the primary focus is on supportive care, ensuring adequate hydration, providing oxygen if needed, managing pain with analgesics, and treating any underlying infections promptly. For long-term management, hydroxyurea plays a vital role. It increases fetal hemoglobin, or HbF, which helps reduce the frequency of crises. Folic acid supplementation supports red blood cell production, and transfusions may be necessary to manage complications. When considering definitive treatment options, allogeneic stem cell transplantation stands out as a potential cure, but it's typically reserved for carefully selected cases due to its complexity and risks. Lastly, transfusion targets are important to keep in mind. The goal is to maintain hemoglobin around 10 grams per deciliter and keep sickle hemoglobin, or HbS, below 30% during exchange transfusions. Overall, managing sickle cell disease involves a tailored approach at each stage, combining prevention, prompt treatment, and, when appropriate, definitive therapies to improve quality of life and outcomes. Let's go over some key triggers of crisis in sickle cell disease. These include infection, dehydration, acidosis, cold, and hypoxia. Each of these factors can precipitate a vaso-occlusive crisis, so recognizing and managing them is crucial. Now, when it comes to osteomyelitis in these patients, Salmonella is the most common causative organism. This is an important point because it influences our choice of antibiotics and management approach. Next, functional asplenia is a frequent issue in sickle cell disease. It increases the risk of infections with encapsulated bacteria, especially Streptococcus pneumoniae. That's why vaccination and prophylactic antibiotics are vital components of care. During pregnancy, it's recommended to avoid hydroxyurea because of potential risks to the fetus. We need to carefully plan and manage sickle cell patients who are pregnant, balancing maternal benefits and fetal safety. In cases of stroke, acute chest syndrome, or priapism, exchange transfusion is indicated. This therapy helps to reduce the proportion of sickled cells and alleviate the severity of these complications. Gallstones, particularly pigment stones, often develop due to chronic hemolysis. The excess bilirubin from breakdown of red cells predisposes to stone formation. Iron overload is another concern in these patients, especially with repeated transfusions. Chelation therapy is essential to prevent organ damage from excess iron. Folate supplementation is recommended for those with chronic hemolysis. Since the red cell production is increased, folate supports their synthesis and helps prevent deficiency. Finally, a few key pearls about MRCP. It's a valuable imaging tool in evaluating biliary and pancreatic pathology, especially when suspecting complications related to sickle cell disease. Remember, understanding these points helps us provide comprehensive care and anticipate potential complications. Thank you so much for your attention. I truly appreciate you taking the time to engage with this presentation. As we wrap up, I want to emphasize how important the concepts we've discussed are in achieving our goals. Remember, the key points about innovation, collaboration, and continuous improvement are what drive success. I hope this has provided valuable insights and inspired you to apply these ideas in your own work. Once again, thank you for being here and for your commitment to growth.